All right. Good evening. It's 7 o'clock. Time for our next Facebook Live event. Thank you for joining us tonight. Greetings from the 11th floor of our beautiful Shirlington Clinic. Tonight, I'm going to be taking you through partial knee replacement. I know it's an option that is a very good option for most individuals. Many patients that I see have not heard of partial knee replacement before, so I figured it was a good topic to cover. It's something that individuals might be told they need a knee replacement after they fail conservative measures, and it's just another treatment that we have for folks that may have arthritis of their knee, not severe enough to warrant a full knee replacement, but does have excellent benefit for performance and outcomes, and maybe something that folks are looking for. So my name is McAsey. I'm one of the joint replacement surgeons here at Anderson Clinic. And tonight I'll be basically structured like a conversation that I may have with one of my patients in the clinic area in discussing their knee arthritis and knee replacement surgery. I'll go into a little bit more detail as far as some of the anatomical things that we as surgeons consider in judging whether or not a patient would be appropriate for a partial knee replacement. But I'll kind of take you through some of that thought process tonight and hopefully give you some valuable information on whether or not this may be a good treatment for your knee pain. So discussion tonight, we'll go over what partial knee replacement actually is, look at the anatomy of the knee, and that'll give you a better understanding as far as how partial knee replacement can treat certain forms of arthritis. We'll go over some of the information on who is the right candidate, both structurally and just from a patient preference standpoint. Look at why you may be considering this as the right option for you based on certain age demographics, function that you may be looking for your knee, and pain patterns that people have. One big question is, how successful are they? Will it last? Those are concerns that folks that may be a little more savvy in the clinic may have heard of partial knee replacement before, or have had friends that have undergone partial knee replacement. These are questions that they do ask in clinic. And then finally, we'll end with a just open discussion as far as questions you may have regarding partial knee replacement surgery as well. So we'll start out with just a primer on knee anatomy. So in the differences between partial and total knee replacement, if we think about the knee anatomically as three areas of the knee, there are the two weight-bearing portions of the knee, and then the joint between the kneecap and the end of the thigh bone, referred to as the patellofemoral joint. A total knee replacement is going to resurface all three of these areas, hence the total aspect of total knee replacement, whereas a partial knee replacement is meant to resurface usually one of these areas, either of the medial or lateral weight-bearing surface or the patellofemoral joint. Now, in partial knee replacement, patellofemoral arthroplasty is probably the less common or least common of the partial knee replacements that we may do. Medial knee arthroplasty, and we'll go over some details of this later on, but medial knee arthroplasty is probably the more common one. And lateral partial knee arthroplasty is the third type. But those are the basic differences. And it's just resurfacing one of these three areas of the knee joint. And with that, there's removal of the cartilage and meniscus, which are oftentimes, found to be degenerative in the knee and progression of arthritis. And when we look at how that happens, or why does arthritis cause knee pain? What happens with knee injury? There could be a few events that happen. One is that you could damage what we call the articular cartilage, or that's the kind of white cartilage that you see on the end of the thigh bone in this pictorial diagram here. As that cartilage is damaged, it can have cracks or breaks in it that can flake off. That cartilage can essentially fragment inside the knee joint. That debris creates inflammation inside the knee joint. That inflammation ultimately results in a painful, swollen knee. And again, those are most oftentimes the complaints that patients have with knee arthritis: is pain, stiffness, swelling. It's painful to bear weight. or in certain circumstances with patellofemoral arthritis, it may be painful going up and down stairs. And then also with knee arthritis, the other structures that can be damaged as well are the menisci. These are more kind of load sharing mechanisms between the round end of the thigh bone and the flat shin bone. It acts to kind of distribute that load evenly through that round thigh bone on the shin bone. And in the instances where that is torn, anytime you have motion between the thigh bone and shin bone, that meniscus can get caught or pinched, lead to pain, can lead to mechanical symptoms, and even further degenerative process as far as the surface cartilage of the knee joint or that articular cartilage wearing away, because when you lose that normal weight-bearing or load-sharing structure, now you essentially have point loading of the thigh bone on the shin bone, and that increases the contact pressure further, leading to more arthritis or more wear of that articular cartilage. So when you look to the bottom right-hand side of the screen, this is essentially looking at what we see as surgeons in the operating room of someone that has that full thickness cartilage loss on the end of their thigh bone, where if you look at the right-hand side of that photo, that's what normal cartilage usually looks like. It's a very rubbery, very smooth surface. And when you look at the left side of that photo, you see the large area of underlying bone that's exposed from the loss of cartilage. And that's what, again, results in the pain, inflammation, and swelling of arthritis. So how do knee replacements work in treating arthritis? There are some folks that have concepts of, knee replacement is a very aggressive surgery or maybe removing, large segments of bone, when in reality, what I think of knee replacement as is it's more of a resurfacing of the knee joint. If you think about the road outside of your house, if you have a pothole or the pavement starts to buckle, typically the road surface or the road services department will come along and they'll take out that area of pavement, smooth it out, and smooth that over to reflatten the surface. They usually won't come in and tear up the entire road and start over. So that's the concept of how I think of knee replacement, is we remove a very thin wafer of bone and the worn out cartilage from the end of the knee, along with the meniscus of the affected area. And then we place these metal caps that go on each end of the bone. And in between those metal caps, there's a plastic surface that becomes the new cushion or the load-bearing mechanism of the knee joint. So technically, when we think about knee replacement, it's more of a resurfacing of the knee joint. And most of the external soft tissue structures, the ligaments that surround the knee, are left intact. With many knee replacement designs, we do have to remove the anterior cruciate ligament, which is an important stabilizing feature of the knee and helps with higher performance activities. Whereas in a partial knee replacement, we don't have to, really do anything with those cruciate ligaments, which are helpful with the feel and function of partial knee replacement, which we'll talk about here in a little while. So these are just examples of the differences of what we see with a knee replacement or a total knee replacement on the left side, and different types of partial knee replacements on the right side. So on that left side, this is the mechanical nature of that knee replacement, where the metal caps on each end. The top side is the metal cap on the end of the thigh bone. The bottom metal part is the plate and stem that goes into the shin bone. And then that white insert in between is the plastic insert that becomes the new wear and tear surface of that knee replacement. And then the small little button that we see in the front of that implant is the patellar button, and that's the surface that we were able to put on the back side of the kneecap, to resurface all three portions of that knee joint, both weight-bearing surfaces and the patellofemoral joint. Now, if we look to the top right-hand side, this is a picture of the weight-bearing partial knee replacement, or a medial and lateral knee replacement, where it's a much smaller surface that is involved with the metal cap on the end of the thigh bone on top, the metal plate on top of the shin bone, and that white plastic bearing surface between, and that can go on either side of the weight-bearing portion of the joint. To the bottom right, we see an example of a patellofemoral arthroplasty. This is essentially kind of the very top front part of that total knee replacement to replace just the patellofemoral joint. And that's made up of a small metal cap that goes on the end of the thigh bone and a plastic button that resurfaces the back of the kneecap. So when I see a patient in the office, the things that are going through, my mind as far as who may be the right candidate for partial knee replacement usually comes down to a few things. When I look at their x-rays, do they have an isolated pattern of arthritis, meaning is one of the three portions of their knee solely affected, and it's not a generalized pattern of arthritis. Number two, on clinical examination, do they have certain features that may be favorable towards success with the partial knee replacement? It may be something like isolated joint line tenderness. If I push on one part of the knee and that's where they've got pain at, but the other areas of the knee that could be involved are pain-free, that's a good candidate for a partial knee replacement if their x-rays dictate. And then finally, failure of conservative treatments. Usually folks are going to come in, they have had some sort of treatment, whether it's been anti-inflammatory medications, they may have been through some form of physical therapy, may have tried things like injections, whether cortisone injections, viscosupplementation injections, PRP injections. They've usually done some sort of treatment. Surgery is generally not the first line treatment unless, they come in so far along in the process that it's unlikely that conservative treatments will fix the problem. But usually with partial knee replacement, patients have, been down some sort of path of non-operative treatment by the time they see us. So in thinking about, the good sides of partial knee replacement, there are good benefits to partial knee replacement, and it usually is a less invasive surgery. It's not as soft tissue and not as bony intensive of a surgery as it is with the total knee replacement. So that generally tends to lead to a quicker recovery. And then some of the things that we touched on before about retention of those cruciate ligaments, particularly the anterior cruciate ligament, is important for knee stability, particularly with lateral movements and rotational movements of the knee. That partial knee replacement tends to have a better function with than with a total knee replacement. In a total knee replacement, we're oftentimes removing the anterior cruciate ligament and sometimes the posterior cruciate ligament, depending on the design of the knee. And that can be good for inline activities or straight ahead activities, but for rotational activities or lateral movements, total knee replacement might take a step back from the partial knee replacement. So when we look at this study that I've got highlighted below here, this is out of HSS. This is looking at unicompartmental knee arthroplasty, has a lower joint awareness. And that just means how much does someone think about their joint replacement after they have it done? And when they look at unicompartmental knee replacement or partial knee replacement and compare that to folks that have total knee replacement, at 5 years, they did find that the unicompartmental knee replacement group had a lower awareness of their joint, better pain scores, and better performance scores compared to a total knee cohort at 5 years. So especially in the early phases, unicompartmental knee arthroplasty or partial knee replacement has benefit, as far as patient satisfaction and performance than total knee replacement. This is a recently published study from Utah that looks at, the recovery of partial knee replacement surgery. Again, because it is a less invasive surgery, it tends to recover quicker than a total knee replacement. And as a joint replacement surgeon, I always kind of think of the best patients after a joint replacement are the hip replacement patients. Those folks do exceptionally well. Oftentimes they recover very quickly in a matter of weeks. They're oftentimes back to doing their basic day-to-day activities with relatively little limitation. Knee replacement patients can take a bit longer than that. It sometimes may be a month or two before total knee replacement patients are at the level that a hip replacement patient would be. What this study found is that when they compared their recovery of partial knee replacement patients and total knee replacement patients, that the partial knee replacement patients actually recovered more on par with the total hip replacement patients than they did with total knee replacement patients. So probably not quite as good as a total hip, but at least closer to a total hip replacement recovery than a total knee recovery. So again, benefit here because it's a smaller surgery, less invasive. It does have a quicker recovery, which means people can get back to performing activities a little bit sooner than they could with a total knee replacement. When we look at other benefits, again, as far as the invasiveness and recovery, this is a study done with one of my colleagues, Dr. Hamilton here at Anderson Clinic, that looked at narcotic requirement after partial knee replacement and total knee replacement, and found that patients that underwent partial knee replacement or unicompartmental knee arthroplasty required less overall narcotic use in the early time period at 4 weeks than total knee replacement patients. Again, that generally essentially means that because less invasive surgery tends to be less pain, quicker recovery, all the same things apply. And this is, the typical recovery course of what I see with my patients at clinic as well. All these things kind of hold true, even in my experience. So what are the drawbacks or, the things that people worry about? All that sounds great. Quicker recovery, higher performance, better feel, and less pain. The one drawback to a partial knee replacement is because you're only replacing one part of the joint, there is an opportunity for other parts of the joint to wear over time. And when we look at the international registry data, countries such as Australia and New Zealand that have had 25-year registry follow-up on their joint replacement patients, more contemporaneously here in the United States over the last decade, we've been following this. But when we look at what are the reasons that these things may not do as well as total knee replacement, it's oftentimes because there's progression of arthritis, secondarily unexplained pain, and third most common reason are loosening of the implants. But by far, progression of arthritis or arthritis that may develop somewhere else in the knee joint is the most common reason that folks may have a failure of their partial knee replacement over time. So we look at what this means. This is primarily for patellofemoral replacement surgery. So not medial or lateral unicompartmental knee arthroplasty surgery, but just for patellofemoral arthroplasty surgery. And at 15 years, survivorship is around 64 to 63%, which isn't great. But when we break this down into different age groups, folks that are younger or less than 65 do have kind of a higher failure rate. They tend to be more active, higher performance, and more opportunity to develop arthritis in the weight-bearing portion of their knee that's not resurfaced, which tends to lead to that higher failure rate. Whereas folks over the age of 65, it is much better performance over time with less failure rate. And oftentimes, again, that may be due to physical demand and activity levels kind of taper off a little bit as we age. When we look at survivorship of medial and lateral partial knee replacement surgery, on the left side, we're looking at data from the Australian registry, and on the right side, we're looking at data from the American Joint Replacement Registry. Again, the most common reasons for failure are progression of disease, loosening, or pain. And oftentimes when we look at 20 years down the line for a partial knee replacement, the survivorship of that partial knee replacement is about 70%, estimating it's a little bit higher than that, but about 70% is the number I quote oftentimes to my patients. And we look at that comparison survivorship to total knee replacement over that same time period. Total knee replacement has a survivorship of about 90%. So essentially 9 out of 10 total knee replacements are still around and functioning well at about 20 years, and about 70% or 7 out of 10 partial knee replacements are still around and functioning at 20 years. So okay with the partial knee replacement, but superior survivorship because there's less opportunity for development of arthritis elsewhere. So for folks that are looking for a one and done sort of surgery, that's where total knee replacement may be the better option for you. Now, when we look at the American Joint Replacement Registry over the last 12 years, their numbers are a little bit lower than the Australian registry. And some of this is dependent on physician reporting and data capture. But essentially, they're looking at about a 4% risk over 12 years of failure with a partial knee replacement and 3% overall risk of failure at 12 years with a total knee replacement. So again, total knee replacement does have better durability than partial knee replacement, but not as wide of a risk of revision, at least at the midterm portion in the American Joint Replacement Registry. So let's look at a few examples here of what these things mean. This is a patient that has undergone a patellofemoral replacement, where here are this patient's preoperative x-rays, where we see from left to right, on the left side, the weight-bearing surfaces have nice wide open joint space. No real arthritis seen here. When we look at the lateral view or the side view in the middle, that joint space is preserved through the back of the knee as we look at the knee in a flex position. But when we go to the far right picture, this is looking at the patellofemoral joint. And here we see that the joint space is narrowed on the outer aspect where the bone is touching bone. And this patient presents to clinic oftentimes with pain, prolonged sitting in chairs, pain going up and down stairs, pain getting up and out of chairs, but they can walk in limited distances and they can do standing and weight-bearing activities without much limitation. And oftentimes they've failed conservative treatment with injections and therapies. So we did discuss a patellofemoral replacement, and this is what it looks like afterwards. So again, left to right, we see that the weight-bearing surface is untouched, but we resurface the worn out portion of that patellofemoral joint with a metal cap that goes over the end of the thigh bone where that patella articulates or rubs against the thigh bone. And the patella gets a plastic button on the back side of it to resurface that portion of the joint. And this again is oftentimes meant to help with that pain with up and down activities or stairs and chairs. Moving to the next example, this is a patient that has medial compartment arthritis. So when we look from left to right, this x-ray on the very far left is just the standing x-ray of the patient where we see that the joint space is preserved. There's a little bit of narrowing towards the medial or inner aspect of the knee, but this is magnified when we turn the patient around in that second radiograph and we get them in a bit of a squat position. And here we can see that that joint space completely goes away and they're bone on bone. Again, on the lateral view or that third x-ray, they maintain their joint space in that deep flexion view. And in the far right x-ray, they maintain that joint space on the patellofemoral view. So this patient underwent a medial unicompartmental knee arthroplasty where, again, we just resurfaced the inner aspect of the knee, here with the metal and plastic parts. And interestingly enough, this patient had a total knee replacement for their opposite knee for other reasons from a traumatic injury. And when this patient came back to the clinic at the long-term follow-up and asking her, do you prefer one knee over the other? She likes the pain relief from both of the knees, but she did say that their performance and the overall feel and function of their partial knee replacement was more normal than what her total knee replacement is. So she kind of borne out what's been described in all the data as well from research. This last patient is an example of a lateral unicompartmental knee arthroplasty. And here we can see in the weight-bearing x-ray that the lateral compartment here is where the wear and tear is at. The patellofemoral joint is maintained. And when we look at what this looks like, this is just the opposite side of the knee from that medial unicompartmental knee arthroplasty, where again, those surfaces are resurfaced with metal and plastic to reproduce that joint space and alleviate that bone rubbing on bone, which causes pain. So those are some examples of folks that have undergone partial knee replacement surgery. At this point in time, I want to thank you all for joining us tonight. Certainly I'd be happy to take any questions that folks may have regarding this, and we'll go over some of the ones that we have currently. But if you do have any other questions or you need to see us in clinic, if you are considering knee replacement surgery or partial knee replacement surgery, I myself or the number of joint replacement colleagues that I have in the practice who do these surgeries be more than happy to see you. So we'll go ahead and start out with some of the questions that in some of these we already did kind of go over, like what are the advantages and disadvantages of the partial knee replacement. So certainly the advantages of the partial are, usually quicker recovery, less invasive, tends to be less painful. The performance or the feel of the knee tends to feel more like your normal knee. And for folks that may be looking at maintaining a higher degree level of activity after their surgery, whether it's, playing some pickleball or racket sports or, getting back to skiing, certainly Lindsey Vonn in the news with her lateral unicompartmental knee arthroplasty has gotten back to skiing. I don't know that I expect that of my patients, but, those are really the true benefits of the partial knee replacement. And the main disadvantages, again, are, potential subsequent surgery that may be necessary. Next question is, how long does the surgery typically take? The beautiful thing for the patient is, you get sedation for the surgery. So to you, it seems like a nice 5-minute nap. But in general, the surgery itself, it's about 45 minutes probably of working time. And then altogether with the setup, it's about an hour and a half procedure. Patients oftentimes are able to go home the same day. The most commonly used anesthesia that we use for the surgery is a sedation like we discussed. Patients oftentimes receive a nerve block, which helps with pain over the front of the knee, and that generally lasts, folks, probably about 12 to 18 hours. And then the workhorse of what we use for surgery is known as a spinal or a regional anesthesia, which, much like when women have babies or childbirth, they may receive an epidural. It's somewhat like that, where you're temporarily kind of numb from the waist down for about 2 hours. That allows us to do our work. You don't feel anything. And then after surgery, that spinal starts to wear off a little bit more gradually. So it allows the nursing staff time to catch up on pain and everything. And then once you're feeling and moving everything, you can get up and put your full weight on the leg and start bending and moving. And as long as you're safe from a mobility standpoint, you can do stairs effectively, and you're able to use the restroom without an issue. Then folks are oftentimes able to discharge after that. Next question is, how soon will I be able to work, drive, or return to regular activities? So work kind of depends on the type of work that you're doing. Certainly folks that may have sedentary jobs, desk work, computer work, folks can be back to that in probably 2 to 4 weeks. If you are on your feet most of the day, a teacher, you spend 6 or 8 hours on your feet, that may be about 4 to 6 weeks before you're ready for something like that. If you're a laborer, climbing ladders, lifting heavy things, that might be in the neighborhood of about 8 to 12 weeks before you have the strength to regain something like that. As far as driving, if it's the right knee, oftentimes it's really a matter of when you're not taking any narcotics during the day and you have control of your leg to operate the gas and the brake effectively. For a left knee surgery, it's just really when you're not taking any narcotics and you can get in and out of the car. Looking at research studies that look at knee replacement surgery and if patients return to normal braking time after surgery, that's oftentimes about 4 to 5 weeks. But again, a lot of it's patient motivation, and as long as you can accomplish things such as not being on any narcotic medications, and essentially braking safety. And then regular activities, I would say that most folks probably within about 2 to 3 weeks are kind of back to their baseline activities. May not require an assist device or like a cane or a walking stick or a walker at that point in time. So usually in a few weeks, folks are able to start resuming their basic day-to-day activities. Next question is, what lifestyle changes might improve the longevity of the implant? Certainly it's not necessarily the longevity of the implant that's the biggest concern. It's really being able to maintain the health of the rest of your joint. Because again, that's the progression of arthritis elsewhere in the knee joint is the main factor that many folks go on to have a subsequent surgery, like a knee replacement surgery. So with that being said, it's really doing things to promote strength of the lower extremities or strength in your quadriceps muscles that help support the knee joint to reduce any risk of injury. Things like maintaining a healthy weight can reduce stress on the joint, are really the biggest kind of lifestyle factors. But these joint replacements nowadays are pretty darn durable that, your basic day-to-day activities and even recreational activities can still do quite well from that standpoint. Typical recovery timeline, again, the length of stay, or if there is a stay, is usually, being able to go home the same day from surgery. I would say the worst of the pain for most individuals is probably that first 24 to 48 hour period. Oftentimes that then tapers off over the ensuing week or two. Worst of the swelling typically peaks about a week to 10 days after surgery, then that gradually gets better over the ensuing few months. Some of the things that we talked about as far as like return to basic activities and driving, we already went over. Usually around the 2-month mark for patients that want to get back to recreational activities, I allow them start to get a little bit more aggressive at that point in time. At that point in time, most of the bone has recovered from surgery. We just don't want folks getting back and doing impact activities, jumping or jogging too soon, because that can lead to potential fracture and really have a big setback in your recovery. And really during that kind of first 2-month period of time, you're in physical therapy, working on your range of motion, working on your strength. So, usually by around that 2-month time is the recreational pursuits when folks get that back. It does take about 6 months for most individuals to regain their full strength after surgery. So like going up and down a set of stairs without much of an issue, or doing it one at a time feels pretty normal. And then no matter what surgery you have, it takes a year to fully heal and kind of understand what the final range of motion, what the final physical function and mobility will be. Next question. Am I really a Chicago Bears fan? I'm hoping that's not from a Green Bay Packers fan out there, but yes, I am a Chicago Bears fan. I'm from Chicago. As disappointing as they have been lately, I still have to say go Bears. I don't know if that was one of my partners ribbing me or something like that, but yes. But I don't know. Are there any other questions that we have? Okay. Well, I thank you guys all for being here tonight. Again, if there are any questions that you may have or need to reach out to us for treatment of your knee injuries or arthritis, please feel free to reach out. The phone number's on the page here, and this will be available on YouTube or online at some future date. So thank you much for being here. Have a good evening.